Welcome to Stanford Med Matters. I'm your host, Dr. Daryl Oakes, Associate Dean for Postgraduate Medical Education at the Stanford University School of Medicine. Clinically, I'm a cardiac anesthesiologist, and I serve as the Vice Chair of Clinician Educator Affairs in the Department of Anesthesiology, Perioperative, and Pain Medicine. In today's session, we will be discussing GLP-1 receptor agonist therapy with a distinguished panel of Stanford experts in pediatric and adult obesity treatment. We will first review the historical context of these medications, and then we will discuss current treatment guidelines for obesity and explore the current understanding of obesity as a metabolic disease. We will then provide a framework for the utilization of GLP-1 receptor agonists in obesity treatment and conclude with our experts' recommendations for the use of GLP-1s and general advice for clinicians who are treating patients with obesity. Today, I'm pleased to introduce our incredible panel of experts. First, we have Dr. M, a board-certified endocrinologist specializing in the treatment of type 2 diabetes, polycystic ovarian syndrome, and obesity. Dr. Kim is an associate professor at Stanford School of Medicine in endocrinology, gerontology, and metabolism. Next, we have Dr. Pratt, a clinical professor at Stanford School of Medicine and a general surgeon specializing in laparoscopic and robotic general and metabolic and bariatric surgery. Dr. Pratt serves as the director of the adolescent metabolic and bariatric surgery programs at Lucile Packard's Children's Hospital. And finally, we have Dr. Azaguri, an associate professor of surgery at Stanford School of Medicine. Dr. Azaguri serves as the medical director for the Stanford Lifestyle and Weight Management Center and fellowship director for the minimally invasive and bariatric surgery. Let's just begin our discussion. Can you please share a bit about the background and maybe the history of medical therapies for obesity, and maybe a little bit about how we came to understand the importance of GLP-1 receptor agonists?
The interest for medical weight loss therapy has always been there, but I think truly we're entering a new era because the medications currently available to us now are so much more effective. We knew from decades ago that the gut participates in helping control blood sugar and as well as appetite. And we knew that it made hormones called incretins, and one of them being the GLP-1 receptor agonists and other hormones as well. And I think in the future, we're going to see a lot of the drugs playing a role in weight management. And the first of these drugs were the GLP-1 receptor agonists. What we knew was that it really participated in glucose management. So after eating, you increase production of these drugs, and they help you manage glucose by enhancing insulin secretion. And we knew from infusion studies that they were very helpful, but it was hard to develop them as a pharmacologic agent because our native GLP-1s, they get broken down within minutes. And so the trick was to figure out how to have an agent that we can use pharmacologically that didn't get degraded super quickly. And it's really interesting from that point on to where we are today, because exenatide was first approved in 2005 for the management of diabetes. And then from there, we've had so many other agents called GLP-1s in the last 20 years. But I would say right now, probably the most popular ones are semaglutide, and then there's also dulaglutide, and then another agent called tirzepatide, which is not only a GLP-1 receptor agonist, but also another incretin hormone called GIP. So it's a dual agonist. And what's confusing for people and also physicians alike is there's so many of these agents, and some of them are approved for diabetes, but more recently, they have become approved for the management of weight. But in the United States, sometimes when you brand for one disease and another, you need to have a different brand name. So for example, semaglutide was initially approved for the management of diabetes as Ozempic, which is the name that everyone's familiar with. But then it also got branded for the management of weight as Wegovy. But there's actually even an oral version called Rybelsus for diabetes. But semaglutide is the drug name, but then there's different brand names, whether it's managed for diabetes or for weight management, but it's the same drug. The new era that I'm talking about is there are these GLP-1 agonists now approved for weight management. And the reason I call it a new era, because these drugs provide a degree of weight loss that we have not seen before. I have been practicing, not to date myself, but for decades now. And I always say this, I feel like a superhero now because I have these agents that can really help patients improve their health. And what I mean by that is, I'm sure, Dr. Oakes, when you were training too, we tell patients any amount of weight loss can help, which is true, especially for the management of something like diabetes to improve blood sugar. But we always said something like, 5% is enough. But now with these agents, we're really getting effective weight loss up to 10% and more, which was unheard of before. Because you asked me about the history of medications. We do have other agents that are approved for weight management, but really we were lucky if they got us 5% weight loss. And now we're in an era where we can get 10% or more weight loss. So these agents are much more effective for patients and also much safer as well.
It's interesting because for us bariatric surgeons, and I'll probably say this multiple times in this video, but the reason we're really comfortable with GLP-1s is that we've been managing GLP-1s for decades. One of the mechanisms behind the surgeries that we do is GLP-1. And actually, one of the ways that GLP-1s were identified is thanks to bariatric surgeries. Historically, what happened was when we started doing gastric bypass surgeries back in the 70s, we realized that patients stopped being diabetic within days of the surgery. And the thought process before was that it was weight loss that led to improvement of diabetes. But here there was a new mechanism that really had to be identified in terms of something was happening within 24, 48 hours of the surgery before patients had lost any weight. And when they started looking into what those causes were, obviously what had to be hormonal somehow, and led to the discovery and the understanding of these gut hormones. And that's how GLP-1s were discovered. And so both the gastric bypass, the sleeve gastrectomy, are actually, what they do is they boost your internal production of GLP-1, or potentially, which is more correct, they bring it back to a more normal level. And so all the feelings, all of the side effects that the patients have on GLP-1s are things that we've seen with our surgeries. That sensation of not being hungry, those are things that we are used to seeing after these surgeries. And so the interesting thing was, initially pharma said, okay, this is fantastic. We found a receptor. We found this GLP-1 that improves diabetes within days. Let's try to make it. And as they have a very short half-life, so it had to be a receptor. Basically took a little bit of time, but got there to the point of having these GLP-1 RAs. And so we're full circle to those GLP-1s that were discovered in part thanks to bariatric surgery are now used for weight loss in conjunction or instead of bariatric surgery.
How do they now fit into the overall management strategy for patients with obesity?
Our center has a comprehensive lifestyle program. We offer anti-obesity medications and surgery. So when kids come into our program, they come to a teaching session where I describe to them obesity. I describe to them that it's a disease. And most importantly, I let them know that it's not their fault. That it's not their fault. It's caused by genes. You could say it's their grandparents' fault or whatever, but it's not their parents' fault either. They're not feeding them the wrong foods. They need to stop feeling guilty about it because they have a disease. And we know obesity is a disease because it responds to medications and it responds to surgery. And the strongest treatment we have is surgery. It's the one that works the best. It's the one that has the longest outcomes. We have 10-year data showing excellent weight loss, that it's sustained at 10 years in over 90% of the kids that undergo surgery. So we use an operation that's very simple. It's kind of like taking the gallbladder out or taking the appendix out. It's called a sleeve gastrectomy. It takes about an hour. It's done laparoscopically through little tiny incisions, and it's highly effective in children. In fact, it's far more effective in children than it is in adults.
The guidelines for weight management, or how these drugs are approved, is that you need to meet a certain criteria for body mass index. I'm a little against that because I don't think it's necessarily a disease of body mass index, but that's where we are right now. Just so that everyone's on the same page, currently medications for weight loss are approved if you have a body mass index of 30 or greater, or 27 and greater, with a comorbidity commonly seen with being overweight or obese, such as increase in glucose like type 2 diabetes, hypertension, dyslipidemia, sleep apnea. So I'm sure physicians are aware, but when we talk about obesity, we're talking about excess fat, which body mass index is a surrogate of, and it can be good in a lot of ways because it's simple to capture, especially in clinical medicine. But what we're really trying to get at is excess fat and excess degree of abnormal fat accumulation, which obviously the body mass index alone doesn't capture. But again, here we are. And a lot of my research work focused on the abnormal effects of excess adiposity. And one of the things that it can lead to is increase in insulin resistance. It can increase risk for diabetes, but even when you don't develop diabetes, it can increase risk for a host of a lot of other diseases, including cardiovascular disease. And so when we're really using these medications, we're hoping to help patients improve their health. And I think the patients that benefit the most are patients with excess adiposity that are at risk for these diseases. I still believe that there are individuals who are obese but insulin sensitive, or individuals where the BMI may be high, but they don't have excess adiposity. But I think at this point right now, it would be nice to get these drugs available and approved for patients who could really benefit.
Has the practice of obesity management and treatment changed significantly since the development of these GLP-1 receptor antagonist therapies have really come on the rise?
Yeah, it's changed our entire sort of management. It's been what the true definition of a game changer in multiple ways. I think one is we had created already here a sort of holistic weight loss program, and really allows patients to come in, be referred because they have a certain condition, just like any other condition, and us to offer a gamut of treatments that are effective, and we can tailor the treatment to the patient. Some patients will benefit from a GLP-1 first, some patients will benefit from surgery directly, some patients will benefit from a conjunction. So we use them in all sorts of ways. We use them solo, we use them before surgery, we use them after surgery. And so the way that I would explain it is it's the same mechanism, and you're just increasing potency. So the way to think about the potency of these weight loss drugs is, if you think about the Saxenda, which is Wegovy or Ozempic, you have a weight loss of about, let's call it about 15% of total body weight loss. You go to 20% with tirzepatide, Mounjaro or Zepbound, and then you go to 30% with weight loss surgery. And that is true not only for the effect on weight loss, but it's interestingly true for all the other effects. So for example, the new study that came out showing the benefits of cardiovascular disease, what we know from bariatric surgery is we see a reduction in cardiovascular disease of about 50% of cardiovascular events. And you cut that in half, that's about the 20% that you see with GLP-1s. So it's, for all intents and purposes, you can count it as a 1-to-2 ratio. to put that in perspective in numbers, I like to use an example. So if you have a patient who comes in at a BMI of 55, and BMI is not perfect, but let's just say about 80% of my patients are women. And if you have a patient who's about 5'5", 300 pounds, that's a BMI of 55. If we put them on semaglutide, they will lose, let's say on average, that's about 45 pounds of weight loss, end up at a BMI of 47. With Mounjaro, that's about a 60-pound weight loss, and that's a BMI of 40 at the end of treatment when they plateau. And we'll talk about plateaus in a second. And then if we were to do a sleeve gastrectomy, that's about 90-pound of weight loss. They get to BMI of 35. A gastric bypass, that's 100 pounds of weight loss, a BMI of 33. So you can see the scale of treatments and how we can adapt it based on how far patients are from an ideal weight and how we tailor those treatments.
The GLP-1s are great because what they help people see is they see that it's not their fault. They see that there's actually a medication that can help them. And that medication is an endogenous hormone. It's a hormone that's produced by the body. So in normal patients who do not have obesity, they may have higher levels of GLP-1 baseline. So a patient who has, for example, genetic thinness, who can eat whatever they want and not gain weight, makes more GLP-1 than a person who has obesity. So it's sort of proof to them that it's a disease. And so I think kids are more willing to accept treatment, and parents are more willing to start treatments. And then the GLP-1s have excellent weight loss. Now we can do surgery, add medications, and get them down to a healthy weight.
You made a reference to some of the issues around accessibility, and so I think it's worth discussing the shortages that have been experienced around these medications, including the limited amount of insurance coverage or very specific coverage parameters. And they've obviously exacerbated maybe long-standing issues with accessibility to therapy for obesity. I'm curious if you have any thoughts about what we can do as physicians and healthcare professionals to help elevate and address these concerns and maybe to help better advocate for our patients.
We need to advocate insurance companies. We need to advocate for the kids through, and it's the same thing we do for surgery. So surgery is denied 50% of the time. We have to do a peer-to-peer discussion with the insurance company and the medical director of the insurance company in order to get the surgery approved. We're finding we have to do the same things with GLP-1s. So we often have to do a peer-to-peer to get it approved. And it's difficult. The insurance companies, and especially state insurance, because 60% of our patients have state insurance, they need to cover it. And they need to be asked to cover it. There's no reason that obesity shouldn't be treated just like sleep apnea. You're going to give a CPAP machine to a kid with sleep apnea. You should be giving GLP-1 to them so that their weight goes down, so their sleep apnea goes away, right? But insurance companies don't always make sense.
This is probably the most frustrating part at this point, and all of the people who work in our clinic if we could eliminate that aspect, it would be incredible. Yes, there's a shortage, but that, I think, over time, although there's some debate about, it's clear that the companies are not going to be able to do these weekly injectables at scale. You can't scale it like you can scale pills. So there are some long-term challenges there, but ultimately we'll get better. There's going to be more manufacturers, and so that will improve. I think the challenge as a healthcare system is, how do we pay for these, and insurance companies not paying for them? Now, the challenge that we have with insurance is not only that they don't approve it, but they, as is usual with insurance companies, they make patients and us jump through hoops, and those hoops are not defined in advance. If they cover it, then they require pre-auth, and the pre-authorization is usually a black box. There are no criteria for. They ask us sometimes to do tests that we haven't done in decades to rule out diseases, and it's unclear if they want a positive response to cover it or if a negative response, and so it's very frustrating. I think from a provider perspective, what we can do is advocate for our patients, is talk to insurers. There's lobbying that needs to happen, but we need to find ways for insurers to pay for this. Now, ultimately, I think it's going to take time.
The access I can't tell you how many calls we get because patients can't find these drugs. And right now, I would say the companies that make these drugs it's their top priority to improve access. And if I could say anything to the companies, I would even have them consider different ways of producing the injectors, because right now, I don't know if you know this, but both the agents approved for weight loss, tirzepatide and semaglutide, it's once weekly, and it's 1 pen, 1 dose. And so I feel that it's environmentally not great. In addition, one of the rate limiting factors of producing these drugs are these injectors, because you have to make a ton of these injectors. So I'm hoping that in the future, we have different ways that we can be mindful to the environment as well as enhance production. I'm also looking forward to other agents coming in the pipeline, because I think the competition will also help with the cost, because it's not only the access, but the cost and insurance coverage.
What GLP-1 receptor agonists are currently available for the treatment specifically of overweight and obesity? And which agents should be considered in patients with obesity and maybe other comorbid conditions like type 2 diabetes or maybe cardiovascular disease? Are there choices that you make related to the different aspects of the agents?
In terms of weight management, there's actually only 3 GLP-1 receptor agonists currently approved. One is liraglutide, another is semaglutide, and the third is tirzepatide. But again, tirzepatide is a dual agonist. It's both a GLP-1 and a GIP agonist. Liraglutide is given once daily, and the brand name for weight management is called Saxenda, whereas the brand name Victoza is for type 2 diabetes. I think this drug is going to get phased out because it's much more convenient and popular for patients to use a once weekly medication. So then comes semaglutide. It's branded for Wegovy as Wegovy for weight management, and as Ozempic for management of type 2 diabetes. And that's once weekly. And then the final one, the tirzepatide that I mentioned, it's branded as Zepbound for weight management and as Mounjaro for management of type 2 diabetes. There's one other GLP-1, dulaglutide, which is branded as Trulicity for diabetes only and not as weight management. And then there are some other shorter acting ones that we're not using as commonly. So I'm not going to talk about that here. If I had all the resources in the world, I would like to choose the most effective agent. And I would say currently that agent is tirzepatide. It's more effective for weight management, and it's more effective for glucose management as well. These medications, whenever I say it, I just think, oh my gosh, I'm in an alternate universe, because we are now, as I said, we're able to get over 10% weight loss starting from baseline weight before starting these medications. And for individuals without diabetes, the semaglutide, branded as Wegovy for weight management, can give us about 15% average weight loss. Average, meaning some people, 50% lose more than 15%, but 15% lose less than 15%. And then with tirzepatide, branded as Zepbound for weight management, we're getting 20% weight loss. 20% average weight loss. So again, 50% will lose more and 50% will lose less. But these are degrees of weight loss we could not even imagine. Before, we were talking about the older drugs. We were able to get maybe 10%. And then we had surgical management that was giving us over 30%. And now people used to talk about the gap in between, and we're completely filling this gap. And there are agents coming out in the future that we've already seen preliminary evidence, and it's giving us 25% weight loss. And I know I still sound so excited, but it still seems amazing to me.
So all of the GLP-1s are not FDA approved for use in kids for the treatment of obesity. So GLP-1s have been out since like 2005 or so. They were used for diabetes for many, many years. But they were not FDA approved in kids at all until about 5 years ago, until 2017. And the first one we had was liraglutide, which resulted in about an 8% total body weight loss, not as much as semaglutide. Now that we have semaglutide, which has been out for 2 years, we have an effective treatment that actually results in half the weight loss we can get with surgery. And in patients who have a lower BMI, it's a perfectly acceptable treatment long term.
As an anesthesiologist, I am very interested in the side effect of decrease in slowed gastric emptying, given the risk of perioperative aspiration. And I know we don't have any definitive studies, but I'm curious perspectives on that.
I think there's still missing data. I will tell you on a day-to-day basis. At this point, I don't know if it's the majority, but at least 50% of my patients are on GLP-1. So when we take them to surgery for a bariatric procedure, we simply stop it a week before and we resume it right away after the surgery. And we've so far haven't had any issues in terms of aspiration. Given that most of the GLP-1s are weekly injectables, it's pretty easy to say, whatever your injection day is, just halt it that Friday before your surgery and then resume it right after the surgery.
Obviously, from the endocrine perspective, as you can tell, I use these medications pretty actively. And when I see that they've improved patients' health in so many ways, especially patients with diabetes, if these medications have improved glucose control, it's so disheartening when they need surgery and the anesthesiologist tells them to stop them, because then we worry that the glucose will increase. In addition, it has a really long half-life. It's weekly medications. And so stopping them for a couple weeks, it's unclear that it will have the intended benefit that the anesthesiologists want, but then the glucose benefit may diminish, and we don't want that perioperatively. I just don't think we have good data for that. I will tell you, we're just in the throes of publishing a paper on this exact topic showing that there is no harm. But of course, I'm not there in the perioperative setting, actually holding the hand of the patient, getting anesthesia, worrying that they're going to regurgitate. But I would say so far, I haven't seen that kind of evidence. I don't want to minimize the side effects. I think it's very important to prepare patients for the potential side effects. It decreases appetite, and it can do that in two ways. The main way is centrally. It literally decreases sense of hunger and appetite. And there have been these studies done where you have someone go to a buffet, eat as much as they want. So like before and after the drug. And generally people eat about 25 to 30% less. So it decreases appetite. But another way it can do that is it slows down gastric emptying. So you do feel fuller. Now, that can lead to nausea. Some people get constipated and some people get diarrhea. And so I always prepare my patients. I would say there are some patients who just cannot tolerate these medications. And it's true with any medications we offer in medicine, right? So another thing is if one patient, let's say a patient can't tolerate semaglutide, then they may do well on tirzepatide or vice versa. And so I've been surprised by that, but it's worth trying a different agent.
There have been studies that have demonstrated some psychiatric effects of some of these drugs, maybe increased rates of depression. I'm curious if the impact of weight loss counteracts that in children, if that's something that's been seen or as a concern in children as well.
Childhood obesity is very difficult. So the quality of life of a child with obesity is the same as the quality of life of a child with cancer. It is very difficult. With obesity, they get teased. There's a lot of bias. People stare at them. It's really, really hard life. And if you've accommodated to that life and then suddenly you lose a lot of weight, that's hard too. And so I do think that there's a strong correlation between depression and obesity. And it's hard to pick out like what causes what. Yes, there's an incidence of suicide with these medications. And there is with surgery too, and there is with no treatment. And it's slightly higher with the medications. And I don't know why that is. I don't know if it's actually a direct effect of the medication on the brain or whether it's something to do with taking them. I don't know. But it is something to be considered because many of them come to us with about 30% come with severe depression or history of severe depression.
What are the current recommendations or guidelines for the use of GLP-1 receptor agonists in pre and post bariatric surgery management? And does the weight loss that results from GLP-1 agonists differ significantly from the types of weight loss that is seen and achieved by surgical management?
I would say in terms of efficacy and comparative efficacy, it's what we talked about a little bit earlier. You can think about GLP-1s as about half the effectiveness of surgery. And there's obviously advantages and disadvantages to those. The way that we use it, first of all, criteria. So criteria, in order to qualify for bariatric surgery, you have to have a BMI of at least 35. And the new guidelines are independent of the fact that you would have comorbidities related to your obesity. So BMI 35 and above, you qualify for weight loss surgery. BMI 27 to 35 and above, you qualify for GLP-1s. So that's a first aspect. The second aspect is you have to think about these there is a certain amount of weight loss that you will obtain from each treatment. You're going to plateau at some point. And that's when we say the average weight loss is patients will start losing weight. At some point, things are going to balance out. And so you get to a new long-term plateau. And that's usually the amount of weight loss that you're going to get from that treatment. So then you can escalate treatment up to break that plateau. There are different ways to break it, but one way is to change the treatment, either to go to a different molecule or to go to surgery. And so we use it in a little bit of either a sequential way or in an alternative way. You treat the patients first with medications, have as much weight loss as possible, and then go to surgery at a time where they've already lost a significant amount of weight. And we see incredible benefits in that, both from your perspective as an anesthesiologist. I just operated on a patient, a slightly older patient, 67 years old, with multiple comorbidities, COPD, asthma, on oxygen at home, and starting BMI of 74. We worked with her for about a year and a half to 2 years, and she did incredibly well in our medical weight loss program. We put her on a GLP-1, and her BMI came from 74 to 44. And so she did extremely well from that perspective. Now her comorbidities have already improved significantly. She's in a position to go to surgery in a much safer way. And so we do the surgery at a BMI of 44. This was a few weeks ago. So we'll see where she ends up.
Are there any patients for whom you would not use these agents, or that there are considerations that would make these not a good choice?
In kids, you're talking about putting a child on a medication they're going to have to take the rest of their life. They're very expensive. We've seen in most studies that the compliance to taking them is only about 65% at 2 years. It's really very poor. And we've had a lot of problems with access to the medication. So recently, we're having a better supply chain to get these medications. But for the last 2 years, it's been very difficult to access Wegovy or the semaglutide for patients with obesity, for kids with obesity. You could still get Ozempic for the treatment of diabetes, but if they didn't have diabetes, you couldn't get the drugs. But even if we have access to them, there is the issue that they're not going to result in adequate weight loss to get the patient to a healthy weight. They're not going to resolve their diabetes. They're not going to resolve their sleep apnea. Whereas if we do surgery, we can get all of those gone. So 95% of kids are going to have resolution or significant improvement of sleep apnea, diabetes, fatty liver disease. All of these get better with bariatric surgery. And the reason they do is because bariatric surgery increases GLP-1 production. And I think we really don't have long-term outcomes for the medications in kids. They're helpful, and I think they may be very helpful in kids who have a lower BMI, but we don't know long term if they're going to have to stay on them the rest of their life. We don't know long term if they're going to have unexpected complications like the delayed gastric emptying and reflux we see with the GLP-1s. It's hard to know long term how these medications are going to play out for kids.
Another aspect is really the stigma associated with obesity. How can we as healthcare providers and in our efforts to promote public health work together to really shift the narrative around obesity? Really, it's been one of blame to really one of more comprehensive care and understanding this as a disease process.
I think words matter. And so we really make a conscious effort to shift the narrative away from this being a trait to this being a medical condition you can treat, right? And so you are not obese. You have obesity. It is something that is treated, that is not intrinsically part of you forever. It is something that can be treated like you have hypertension, you have obesity, and you can have treatment for those. And it's part of the narrative of helping patients understand that this is a medical condition and I think GLP-1s are a great tool to do that, to bring patients into the medical realm and move away from obesity being something that you only discuss with friends and family and try to work on your own. I do think that there's still a lot of stigma out there, and there are a lot of providers that see this as a question of lack of will. Nobody would tell you to try to get your blood pressure down by relaxing and taking deep breaths. Yes, it could work theoretically but that's not what we do. That's not how we would treat that disease. And so I think there's really a matter of how we talk about it, how we educate patients about it. And yes, none of these therapies, whether it be surgery or medications, none of them are miracles. And patients actually understand that very well. What these things do is they start to even out the playing field for patients. There's no easy route through this. It's a hard route or hard route. And I think finally having a series of treatments that work and where we can cater to all of the patients independent of their comorbidities and their risk profile and the severity of the disease they have is a great game-changing aspect to what we do.
I think that's great. We really changed the language and changed the approach, and we'll ultimately help them be more effective, and we'll be more effective at supporting that. So thank you so much for that. I think doing this work is so critical to so many people's lives, and it's really life-changing. Any last things you want to make sure that physicians and health professionals who are taking care of this population in different settings, what would you like to make sure we all know?
Treat this as a condition. And I don't think you would ever, as a provider, be, shy, embarrassed, or hesitant about bringing up the result of a test that you do. Like if the blood pressure is up, you're going to say you have high blood pressure. Let's take care of it. So if your patient has obesity, tell them, in a way that we've talked about before, but bring it up and say, you have this condition. Let's treat it. Let's talk about it and let's treat it. And so I think that's the best favor we can do to our patients.
I think, we need more data. We need to know what the GLP-1s do long term. We need to know what the compliance rate is in real life, not in a study where they're selecting patients who are more compliant, who are going to follow the study, who are going to take the medications, but really in real life. And real life use of GLP-1s, what is the follow-up? What is the continued use? Because what I fear is that kids are going to take it, they're going to lose weight, they're not going to be able to tolerate it or afford it or, whatever. They're going to time out of their parents' insurance, and then they're not going to have it anymore. So they're going to reach 18, they're going to go off it, they're going to then regain all the weight and feel terrible. And that weight regain is really difficult on kids. It is on adults too. But if you lost weight from a GLP-1 or from surgery, the last thing you want to do is regain weight, because weight regain is really emotionally difficult for children especially, but also in adults. So What I fear is that we're going to get these kids on GLP-1s and they're going to reach, like I said, 18. They're going to no longer have insurance, or 21 or whatever, whenever it times out for them. And they're not going to be able to get the GLP-1s anymore. And that's a problem. That's a real problem. It's like if you had diabetes and we said, oh, we're not going to give you insulin anymore, which happens also, honestly. And on the other hand, if we take a kid who has severe obesity, we do surgery on them, they don't need insulin anymore. They don't need the GLP-1 because it takes it. We know that surgery will improve diabetes. It will put it in remission 85% of the time in kids, and it will put it in remission permanently in at least 50% of them, meaning they'll never get diabetes again. And so that's really what I'm looking for in terms of treating the kids. I love GLP-1s because they bring out the truth about obesity, that it's a hormonal disease, and they offer extra care for patients who we can't get enough weight off with surgery. But I don't see it replacing surgery. I don't think it is a replacement for surgery. They're not equal, and they're not equivalent in any way.
When you start these medications, you must discuss the side effects with patients and what to expect. And then 2, these medications are all started at a low dose and increase, but you don't have to go to the top dose. Some patients, even at the lowest dose, do really well. And so you don't have to feel like I need to ramp up to the highest dose. Stick to the dose that works. And I think we're still learning even about the speed of weight loss and potential effects. That gets me to the other really important things. Even though these drugs are super effective, it is still important to talk about diet and nutrition, because I think with the amount of weight loss you can get with these drugs, there is a risk for malnutrition. And even individuals who may have excess adiposity may be malnourished in terms of the nutrients we actually need. And so we need more focus on nutrition. Exercise, I tell patients all the time, especially because one of the concerns with these medications is that we want to prioritize losing fat, but you always lose muscle in addition to fat when you're losing weight. So we want to try to maintain lean mass. And the best way to do that is exercise in addition to the weight loss. So I really focus on strength training with my patients when they're on these medications. And I think the nutrition is important. I think we just don't know how the perfect solution for that, but it's important to talk about nutrition. A lot of people talk about especially prioritizing protein intake as well with these, but I don't think at this time we currently know the exact amount of protein and the sources of protein that are helpful. But exercise, I can guarantee you it's going to be helpful. And the last thing I think is important to understand is some people feel that when weight plateaus, it's a failure. We can't have an intervention lead to unlimited weight loss, right? And so we need to talk with patients about goals of where you want to get, where this drug can get you. And the plateau is okay. And at that plateau, maintaining your weight loss is also an active process. It's not something that's just going to maintain itself. We need to remember that weight maintenance is an active process.
As we come to the end of our session, I would like to thank our panelists, Dr. Soon Kim, Dr. Janie Pratt, and Dr. Dan Azaguri, for their expertise in GLP-1 receptor agonist and obesity management. We have covered really a lot of ground in our discussion today. And from the history of these medications, we really sort of got a chance to understand how we got here, to sort of discussions of the current treatment guidelines, a better understanding of the approach to obesity in our current landscape, and some practical recommendations for clinicians as we approach management of this very difficult disease. The field of obesity treatment has really been rapidly evolving, as we have all been experiencing in the last few years, particularly with the evolution of the GLP-1 receptor agonists. And as we explore how to utilize these both in the medical and surgical approaches to this disease, I think there's just so much to learn. And we've discussed today sort of the possibilities of using these drugs in our patients and how important it is to consider the broader context of comprehensive obesity management, and really understanding that this is a multidisciplinary disease that requires a multidisciplinary approach. And when we're considering how we approach this disease, thinking about the specific considerations that pertain to both our pediatric populations, our adolescent populations, and our adult populations. Thank you again for your engagement. Stay informed about our upcoming premieres. Please subscribe to our Stanford CME YouTube channel. Take care.